Hi everyone, my name is Saeed Hashem. I'm an outpatient geriatric psychiatrist at McLean Hospital in Belmont, Massachusetts. I'm also a clinical researcher in the geriatric psychiatry research program at McLean, and I'm an instructor of psychiatry at Harvard Medical School. So today I'm going to resume our overview on major neurocognitive disorders in older adults. So this is part 2, geared towards more advanced practitioners and young learners in the field of geriatric psychiatry. If you haven't watched part 1 of this series, I strongly encourage you to do so. So I have to acknowledge that this presentation is supported by a HRSA grant from the US government, the Department of Health and Human Services. However, the contents of these slides and my presentation do not represent the HRSA or the Department of Health or the US government. I do have to declare some conflicts of interest as I work as a co-investigator on active clinical pharmaceutical trials with Biogen and Eisai investigating the use of monoclonal antibodies in mild cognitive impairment and early Alzheimer's disease. This presentation also includes some off-label therapeutics for Alzheimer's disease and related dementias that were discussed in published medical literature. So to keep things within the same age-friendly framework that we use in our services, among the 4 M's, we will focus on this presentation on mentation and what matters. So let's quickly go over what are the types of major neurocognitive disorders that we know of among older adults. So here's a list of 16 different types of major neurocognitive disorders that can affect older adults, and it's a descending order of known frequency. And as you see at the top is Alzheimer's disease, which is the most common form. In this presentation, we will focus more on the other types of major neurocognitive disorders that can affect older adults. So I realize it's a lengthy list, 16 is a lot. So in the coming slides, I will try to focus on the cardinal signs and the high yield facts of each type of them. So we already discussed Alzheimer's disease in the first part. Again, if you haven't watched that part, I strongly encourage you to see it. Let's talk about the other common major neurocognitive disorders in older adults. So the second most common form of major neurocognitive disorder in this age group is vascular disease or vascular dementia, which is caused directly due to cerebrovascular disease. The clinical presentation usually varies. It may present with non-amnestic MCI, which was further explained in the first part of this series. It can present with a focal neurological deficit with some cognitive impairment. Cued recall is usually better than free recall in these subjects. Gait instability, mood changes, and urinary incontinence is also common. And they may present in different courses. So with small vessel disease, the course may be chronic, gradual decline, whereas in infarcts and hemorrhages, it may present in a stepwise decline. It is the second most common after Alzheimer's disease, accounting to 20 to 25% of cases. Slightly higher prevalence in Japan because they have a higher overall prevalence of cerebrovascular disease. And the peak is usually between the 4th and the 7th decade of life. And 80% of them will have a history of hypertension. So the etiology of vascular dementia depends on the type of infarcts or hemorrhages that are affecting the brain. With lacunar infarcts, the presentation may look like a subcortical dementia. Recurrent strokes may cause multi-infarct dementia with a stepwise decline, whereas small vessel disease usually leads to this chronic, gradual decline in cognition and mood, and it presents as white matter hyperintensities around the ventricles on brain imaging. Cerebral amyloid angiopathy may show as a unique form of vascular dementia, with sometimes it presents with episodic nature of symptoms. The most important risk factors are advanced age and hypertension. Other risk factors include dyslipidemia, smoking, obesity and sedentary lifestyle, diabetes, and a history of prior stroke. These risk factors were according to a large cohort study called the InterStroke, investigating the risk factors, the modifiable risk factors of cerebrovascular disease. Once you cross the age 80 years of age, atrial fibrillation jumps up on the list to be second after advanced age. So the pathology is simple. Brain damage follows the blood supply distribution. White matter is usually more affected than the gray matter. And then you see tissue loss, atrophy, and encephalomalacia after that. The diagnosis is based on history and examination, neuropsych testing, and you may benefit from getting a SPECT scan to differentiate vascular dementia from Alzheimer's disease. So the prognosis depends on the management. Optimal control of the cerebrovascular risk factors that were mentioned in the prior slide, you may reach a plateau or even slight improvement in cognition and mood. If the etiology is untreated, it becomes comparable or worse than Alzheimer's disease. The cause of death is usually the complication of cardiovascular and the cerebrovascular disease itself, such as pneumonia, aspiration, urinary tract infections, or complications of recumbency. Treatment is usually directed at the underlying cause of the cerebrovascular disease. Otherwise, it is managed with the same three pillars of Alzheimer's disease management that was mentioned in part 1, except for the use of monoclonal antibodies. Next on the list is frontotemporal dementia, which is a gradual progressive dementia affecting the frontal and the temporal lobe, so it primarily affects behavior and language before it affects memory. It's an early onset disorder that begins between ages 45 and 65. Only 10 to 20% may begin after 65 years of age, and the course is usually depending on the clinical subtypes, which I will discuss in the next slide. The epidemiology, so it's about 50,000 to 60,000 cases in the United States, and it depends on the population studies. It could be considered as the most common early presenting dementia, and it could be the second most common early dementia after early onset Alzheimer's disease. So there are several subtypes of the frontotemporal disease or frontotemporal dementia. The most common one is the behavioral variant of frontotemporal disease. The other less common subtypes include the semantic variant of primary progressive aphasia and the non-fluent variant of the primary progressive aphasia. There are other much less common subtypes of frontotemporal disease, including the NFID and the BIPD. So the cause of frontotemporal disease is not exactly known. There is a lot of active research in that area. But as far as we know, there is an accumulation of phosphorylated tau and abnormal toxic proteins that bind the DNA, causing neuronal cell death, most of which are related to genes located on chromosome 17. So 10 to 15% of cases are familial due to defects in that chromosome. One important gene defect that you should know is the trinucleotide repeat expansion of the gene C9orf72, which is related to a much worse prognosis and outcomes. It also exhibits anticipation phenomena, which means that the disease manifests at a younger age with each subsequent generation, and it's related to showing more psychotic symptoms in these subjects. So as far as we know regarding the neuropathology, it is a tauopathy with neurofibrillary tangles, and it happens to cause loss of 70% of the spindle neurons in the cortex. These are large cortical neurons, unlike the pyramidal cells that are affected in Alzheimer's disease. So when these neurons are affected in the anterior cingulate cortex, it affects the motivation. If it affects the frontoinsular cortex, it may affect the social cognition. And if it affects the dorsolateral prefrontal cortex, it affects mood, executive function, inhibition, and abstract reasoning. These are the parts of the salience brain network which is responsible for communication, social behavior, and self-awareness. So the diagnosis of the behavioral variant FTD depends on having 3 or more of the following clinical criteria, which include disinhibition, apathy, loss of sympathy or empathy, perseveration or compulsive behaviors, hyperorality, and executive dysfunction on the neuropsych testing. The MRI may show frontal lobe or frontal lobe with anterior temporal lobe atrophy, but in early cases, the scan may seem absolutely normal. The FDG PET scan classically show hypometabolism in the frontal and the temporal lobes, which can differentiate it from Alzheimer's disease, which classically show parietal and temporal hypometabolism. The language subtypes can be regionally dissociated by imaging approaches. So the non-fluent will be more affecting the frontal side, and the semantic variant will be more affecting the posterior parts of the temporal lobe. The prognosis usually is much rapid than Alzheimer's disease when it comes to progression. Survival is somewhere between 2 to 20 years, and it's particularly worse with a behavioral variant, and they eventually will need 24/7 care. There is no treatment, and the management is pretty similar to the 3 pillars of Alzheimer's disease management that were mentioned in part 1, with periodic review of the evolving and emerging symptoms. Cognitive enhancers that could be used for Alzheimer's may actually worsen the clinical presentation in frontotemporal disease, and there is no role for monoclonal therapies at this point. Next is the dementia with Lewy bodies, which is a progressive neurodegenerative disease characterized by the abnormal collection of alpha-synuclein within the neurons, and it is one of the 2 Lewy body dementias along with Parkinson's disease dementia, which I will discuss later. The presentation is usually comprised of core clinical features and other supportive features. The core clinical features include fluctuation in their cognition, recurrent visual hallucinations, REM sleep behavioral disorders, and Parkinsonism. It may exhibit premotor symptoms similar to Parkinson's disease, usually 10 to 15 years before the cognitive decline may present. Other supportive clinical features include marked sensitivity to antipsychotics, marked dysautonomia, hypersomnia, hypoosmia, postural instability, and frequent falls. They may also present with a lot of apathy, anxiety, and/or depression. So it is considered the 3rd most common major neurocognitive disorder in older adults after Alzheimer's and vascular disease. The incidence and the prevalence are not known accurately, but it's roughly 0.4% of those more than 65 worldwide. There is no exact trigger for the buildup of the alpha-synuclein. Family history is actually not common, but the heritability can be up to 30%. One risk factor we know of, aside from advanced age, is the ApoE4 allele, while ApoE2 seems to be protective. There are other genetic mutations that may cause it as well. So the pathology is simple. The alpha-synuclein keeps accumulating in dopaminergic neurons with neuronal cell death, impairing their behavior, their cognition, their mood, their motivation, and their sleep. And then it starts affecting the acetylcholine neurons, causing memory and learning problems. Brain atrophy and pathology seems to be worse than Parkinson's disease dementia, but not as bad as Alzheimer's disease. So according to the 4th consensus report, a diagnosis of probable dementia with Lewy body requires the evidence of dementia, at least 2 core features that we just mentioned, and at least 1 biomarker, which may include a low DAT3 uptake on the PET SPECT scan, which is also known as a positive DAT scan, or a low 1 to 3 iodine meta-iodobenzyl guanidine uptake on the myocardial scintigraphy, or loss of atonia during REM sleep on a polysomnogram study. Other supportive biomarkers include an intact medial temporal lobe on brain imaging, because it's usually affected more in Alzheimer's disease and some cases of frontotemporal disease, reduced occipital activity and high slow wave sleep on EEG. For some clinicians to differentiate between Parkinson's disease dementia and dementia with Lewy body due to the similarities between them is using the 1-year rule. So if the cognitive decline started within 1 year of the Parkinsonian features, then it's probably dementia with Lewy body. If the cognitive decline started more than 1 year after the Parkinsonism manifested, then it's probably Parkinson's disease dementia. So unfortunately, dementia with Lewy body also shows rapid progression, especially if they have one of the alleles for the ApoE4. Orthostatic hypotension, visual spatial deficits, and gait instability usually correlate to worse prognosis due to recurrent falls. Compared to Alzheimer's disease, they have higher rates of disability, lower life expectancy, worse quality of life, more neuropsychiatric symptoms, and an average survival time after diagnosis is between 4 and 10 years. The cause of death is primarily related to falls and failure to thrive. There is no treatment, no cure. The outlines of care are similar to the 3 pillars we discussed for management of Alzheimer's disease. With symptomatic treatment becomes more challenging due to the fluctuations of their symptoms, limited response, and marked sensitivity to antipsychotics. You have to also exercise extreme caution with the use of dopaminergic agents, which may worsen psychosis, using the acetylcholinesterase inhibitors, which can worsen the autonomic symptoms, and the use of antipsychotics may cause extrapyramidal symptoms up to neuroleptic malignant syndrome. Next is the other brother of the same family, the Parkinson's disease dementia, which is a chronic progressive neurocognitive disorder that is associated primarily with Parkinson's disease. So it usually starts with Parkinson's disease for at least 1 year, and then changes in cognition start to manifest. Usually it presents with more tremor, and it's less symmetrical than dementia with Lewy body. 80% of patients with Parkinson's disease have dementia in later stages. Delusions in Parkinson's disease dementia are less common compared to dementia with Lewy body, and the severity of the visual hallucinations are less prominent. Non-motor symptoms or premotor symptoms may include depression and apathy, constipation, orthostatic hypotension, incontinence and erectile dysfunction, and excessive sweating. So the pathology, the etiology, the diagnosis is very similar to dementia with Lewy body. The prognosis and treatment tends to be slightly more favorable than dementia with Lewy body. So now I'm going to discuss other much less common major neurocognitive disorders that can affect older adults. So the first one on this list is the progressive supranuclear palsy, or PSP, which is a late onset neurocognitive disorder characterized by selective tauopathy of subcortical structures in the brain. It presents with significant gait instability, axial extrapyramidal impairment, which means it affects the facial muscles, eye muscles, neck, back, and trunk before it affects the arms or the legs, significant executive dysfunction, and speech and swallow impairment. Two unique features of this type of neurocognitive disorder are the vertical gaze palsy and convergence insufficiency that you see in the eye movements, and also the wide eye stare, furrowing of the forehead, the frowning expression that you can see in this picture. Sphincter dysfunction can happen part of the dysautonomia. So this disease affects only about 6 per 100,000 Americans. The onset is typically more than 60 years of age, and it tends to happen more often in men than women. The etiology is not exactly known, but some toxins have been implicated, like acetogenins, quinolones, and retinoids. The pathology is usually in the form of widespread tauopathy with neurofibrinoid tangles affecting neurons and tuft-shaped astrocytes, primarily affecting the basal ganglia, the midbrain, the frontal cortex, the limbic system, the dentate nucleus of the cerebellum, and the Onuf's nucleus of the spinal cord. So the diagnosis is usually based on history and exam. The MRI may show atrophy in the midbrain with the preservation of the pons, which is called the hummingbird sign. There are different types based on the pathology. So there is the classical PSP, which presents with the typical presentation that we just mentioned. There is the PSP-P, where the tauopathy is more restricted to the brainstem, exhibiting primarily Parkinsonian features, usually has a more benign course. There is the PSP with more cortical involvement, which presents with more FTD-like symptoms. And there is the PSPC, which is very rare, with a severe loss of the dentate nucleus of the cerebellum, causing significant impairment of gait. The prognosis is usually poor and the mean survival is 7 years after diagnosis. The treatment is largely supportive, and levodopa and amantadine may help with Parkinsonism, but not much. So next on the same list is the multiple system atrophy, or MSA, which is a rare neurodegenerative disorder that's characterized by selective synuclein protein deposition affecting primarily subcortical structures, similar to how the Parkinson's disease dementia and dementia with Lewy body can happen, but more selective. It presents with severe autonomic dysfunction, vocal cord palsy, and recurrent falls. With the MSP subtype, you see more Parkinsonian features. With the MSAC subtype, you see more cerebellar ataxia features. And in both cases, cognitive impairment happens later in the disease course. The epidemiology is similar to how PSP presents. About 5 per 100,000 Americans, slightly more common in men, but it presents at a younger age, somewhere between 50 and 60 years of age. And the etiology remains unknown. So the pathology under the microscope for this disease shows neuronal cell loss that begins in the oligodendrocytes, which are naturally responsible for the myelination of the neurons, characteristic intracellular inclusions called the paplantose bodies, which have a different configuration than the alpha-synuclein that we see in Lewy bodies. So the diagnosis is based on the number of features that we have. So with a probable multiple system atrophy, we should see an autonomic failure involving urinary incontinence and significant orthostasis, plus either Parkinsonism that doesn't respond to levodopa or cerebellar ataxia. For a possible multiple system atrophy, you need Parkinsonism or cerebellar ataxia with at least one autonomic dysfunction and one additional feature, which are the vocal cord palsy or recurrent falls. The MRI is usually not conclusive in these cases. So the prognosis is not so favorable. The survival is usually 5, maybe 6 or 10 years after the diagnosis. The mortality is usually related to the severity of autonomic dysfunction, causing infection and a failure to thrive, and ultimately death. There is no treatment, no cure. It's largely supportive, focused on rehabilitation and the management of the orthostatic hypotension, for which you could use either fludrocortisone or midodrine. So next on the list is the corticobasal degeneration, which is another rare tauopathy involving the cerebral cortex and the basal ganglia. Quite selective, huh? So it presents with an older age, usually above 60 years of age. A lot of motor symptoms, including Parkinsonism, dysphagia, and alien hand syndrome, where the hand will move on its own. Cortical symptoms include idiomotor apraxia, kinetic apraxia, and non-fluent aphasia. May present with irritability and depression, and may show features of cognitive impairment similar to frontotemporal dementia. The epidemiology is similar to MSA and PSP, somewhere between 5 and 7 per 100,000 Americans, but this one is slightly more common in women, and the etiology is entirely unclear. So this one, as I mentioned, is primarily a tauopathy, showing ring-shaped astrocytic plaques in the affected tissue, as we mentioned in the cortex and the basal ganglia. Diagnosis is quite hard and controversial. The most recent Armstrong criteria came out in 2013. For the MRI and SPECT may show asymmetrical pathology in the posterior part of the frontal and parietal areas, may affect the corpus callosum, the thalamus, and the basal ganglia. The DAT scan is usually positive. The prognosis is poor, usually 8 years of survival after diagnosis, and the aspiration pneumonia is usually the most common cause of death. Treatment usually doesn't respond to many of the options that we might offer, and it's largely palliative at this point. Next on the list is the posterior cortical atrophy, or PCA. So this is a slowly progressive neurodegenerative disease that causes brain cell death that is more selective to the posterior parts of the cortex, disrupting visual processing. And some consider it as a visual variant of Alzheimer's disease. The presentation is usually a bit earlier than Alzheimer's, so it starts in the mid-50s to the mid-60s. It presents with visuospatial impairment, so reading and depth perception becomes a problem. A lot of apraxia, especially oculomotor apraxia, visual agnosia, and later in the disease it becomes very similar to Alzheimer's. The epidemiology presents around 5 to 15% according to study populations of Alzheimer's disease. The diagnosis, prognosis, and treatment is exactly the same as Alzheimer's disease, with more emphasis on occupational therapy, particularly for these subjects. Next is the normal pressure hydrocephalus, which is a form of communicating hydrocephalus causing the enlargement of ventricles, compressing the surrounding brain tissue. This one usually presents in individuals who are 40 or older years of age. It has a unique gait, which is broad-based, slow, short steppage, and kind of magnetic, as if their feet are like stuck with a magnet to the ground. 60% of cases will develop frontal dementia, which is characterized with executive dysfunction, impaired working memory, slow processing speed, and then you notice some apathy and non-fluent speech impairment. Up to 50% of individuals will have urinary incontinence. The diagnosis is usually based on the history and physical exam. The MRI is usually helpful. It shows some unique features like the enlargement of at least one temporal horn, an acute callosal angle less than 90 degrees, and transepidermal edema within the brain tissue without evidence of obstruction. There is also the Miller-Fisher test, where you drain 50 mLs of the CSF and then evaluate later on. You should see some improvement. And the treatment basically is a VP shunt. So next is the alcohol-related dementia, which frequency is not really known. It's a form of cognitive dysfunction caused by long-term excessive consumption of alcohol, resulting in brain damage. Usually in the 60s, after at least 10 years of regular alcohol consumption. It's a variable combination of frontal dementia, Wernicke's encephalopathy, Korsakoff psychosis with a lot of confabulations, peripheral neuropathy, and a cerebellar ataxia. The etiology is simple. Alcohol causes direct damage to the neurons and glial tissue, and a lot of malnutrition is also involved. The treatment is also simple: abstinence from alcohol and improve the nutritional status. So next is the HIV-associated neurocognitive disorder, or HAND, which is a syndrome of progressive deterioration of memory, cognition, behavior, and motor function in HIV-positive individuals. Usually occurs in the later stage of the disease. So the presentation has been classified into 6 different stages, whereas stage 0 patients are normal mentally and motor functions are absolutely fine. And then stage 0.5, you see mild cognitive impairment, but the gait remains normal. Stage 1, the IADLs can be affected, but the gait remains normal. Stage 2, 3, and 4, the gait and cognition starts to decline, until the patient becomes nearly vegetative and absolutely mute. Um, so this syndrome typically occurs years after HIV infection. It's associated with low CD4 count and a high viral load. Incidence has declined a lot in developed countries due to the availability and access to high quality antiretroactive therapy. The pathology is primarily caused by the virus itself and its invasion of neurons, but it can also be affected by opportunistic infections, CNS lymphomas, toxic effects of medication, and malnutrition. The areas most affected are the hippocampus, the frontostriatal connections, and the putamen. It's unclear why it picks these particular areas, and there is a cerebral brain volume loss overall. So for the diagnosis of hand, you need a marked acquired impairment of at least 2 of the 6 known cognitive domains. The impairment should interfere with day-to-day functioning. It must present for at least 1 month and do not meet the criteria for delirium. There shouldn't be an evidence for another pre-existing cause that may explain the dementia. And this routinely requires a careful history, neuro exam, brain scans, and a lumbar puncture. The amount of the virus in the brain does not correlate well with the degree of hand, but we know the viral load in the body and the low CD4 count does correlate. The prognosis and treatment are poor if untreated, basically fatal, and the highly active antiretroviral therapy can prevent, delay, or improve the symptoms of the syndrome. Next on the list is the prion disease or the transmissible spongiform encephalopathy, which is a group of rare, rapidly progressive, usually fatal conditions. There are several types, with the most common one is the Creutzfeldt-Jakob disease. It usually presents with personality changes, depression, sometimes psychosis. It also presents with ataxia, myoclonus, pyramidal spasticity, and Parkinsonism, and then disturbances in awareness. So it begins with a lot of insomnia, confusion, mutism, coma, and then death. So most cases of sporadic Creutzfeldt-Jakob disease occur between the ages of 45 and 75, around 1 new case per million per year, so it's quite rare. The etiology depends on the type. It could be sporadic due to mutations in the PRNP gene, which normally regulates the copper transportation within the cell. When it's mutated, it produces toxic proteins that starts destroying neurons. The familial forms are caused by inherited mutations, and there is a transmitted form due to the exposure of prion contaminated tissue, either through ingestion or iatrogenic. The pathology is basically neuronal cell death with spongiform changes, and you can see the accumulation of the amyloid plaques and the prion protein under the microscope. So the diagnosis of prion disease, usually upon clinical suspicion, you should seek CSF analysis for the quick-induced conversion, which is the gold standard for diagnosis. Other supportive tests include the detection of the 1433 protein and high tau protein content. The imaging, including the MRI DWI, will show hyperintensity in the cortex, striatum, and the putamen. And the EEG will show the periodic synchronous biphasic or triphasic sharp wave complexes. The prognosis is pretty poor. Patient usually dies within 6 to 12 months from the onset of symptoms, and the treatment is mostly palliative care. Next is the new addition to the list, chronic traumatic encephalopathy or CTEs, which is a tauopathy caused by repeated head trauma. Usually presents around 10 years after the repetitive TBIs. Stage 1 usually starts with a confusion, dizziness, headaches, sometimes some mood changes. Stage 2 shows mild memory loss, executive dysfunction, impulsivity, and poor judgment, so mostly frontal symptoms, and it can present with some paranoia. Stages 3 and 4, the disease becomes more advanced with dementia, Parkinsonism, deafness, vertigo, and the depression may progress to become severe with suicidal ideation. The rates of the disease have been found to be around 30% among those who suffer repeat multiple head injuries, and was found in some degree for 99% of tested NFL players, also hockey players, and military personnel, especially those who served in mountain areas. So it's mostly caused by contact sports, but it can also be caused by combat sports. The pathology is usually characterized by deep parenchymal phosphorylated tau aggregations around small blood vessels. These are usually pathognomonic, and then it spreads to other brain regions. The diagnosis, nothing really is available except by brain autopsy. Treatment is nothing is available, and it's mostly symptomatic care. So that brings us to the end of our exhaustive list of causes. However, there is one more cause that I'd like to talk about, which to me is last but not least. That is the reversible causes of cognitive impairment. And I can't stress enough how important excluding these causes are, because I've seen in clinical practice multiple patients, older adults, who present with cognitive impairment that is quite profound, that you may think this is straightforward Alzheimer's disease. And when you look for reversible causes, you find at least 3 or 4 of them. And upon treating those causes, the cognitive impairment almost resolves. So here's a simple list for the reversible causes of cognitive impairment that may affect older adults. The first one is delirium, because the recovery from delirium in older adults may be protracted and prolonged, which may mimic dementia. Depression is another big one because it presents a lot with cognitive impairment, especially in older adults, something that we call pseudodementia. You should look at the list of their medication, any substances they are using, including herbal compounds. Blood work should show any metabolic derangement, hypothyroidism, or vitamin deficiencies. Other miscellaneous causes of cognitive impairment may include epilepsy, anemia, sleep disorders including sleep apnea, and CNS infections or tumors. So now that we've learned the types of neurocognitive disorders, including reversible causes of cognitive impairment, how should we approach a patient coming to the clinic presenting with a cognitive concern? So in the next few slides in this section, I'm going to discuss a suggestion for a diagnostic approach that you can use in clinical settings. And unlike what you may think, Alzheimer's is the most common cause of cognitive impairment in older adults. However, it remains a diagnosis of exclusion, which means that you have to exclude other causes before you consider Alzheimer's disease. So here's a suggested diagnostic approach to deal with these patients in clinical settings, which I will detail in the coming slides. First is history taking, which must include a reliable informant for collateral history, a physical exam including vital signs, a neurological assessment which should include speech evaluation and gait assessment, so you need to watch them walk and hear them talk, a cognitive testing, and then screen for depression, which is a famous reversible cause for cognitive impairment. Labs are needed to rule out any reversible causes. Brain imaging usually handy, either to confirm your most probable diagnosis or exclude other possibilities. Special tests may be needed as indicated, and then you reach a probable diagnosis with some differentials. So the first step, as I mentioned, is history taking from the patient and a reliable informant for collateral. That should include the onset, the course, and the duration of the illness. You have to screen for cognitive symptoms and neuropsychiatric symptoms. You should do a detailed assessment of functioning, including the activities of daily living and the instrumental activities of daily living. Obtain a good past history, including past psychiatric history, a family history of cognitive issues, possible exposures, whether it's occupational or environmental, and a social history, including current social supports. The physical exam can be crucial, especially vital signs and ruling out orthostatic hypotension. Body weight and their BMI can also be important. Doing a head-to-toe examination, and you focus on risk factors for cognitive impairment and alternate etiologies. You may need a focused neurological exam, focusing on the cranial nerves, pyramidal system, extrapyramidal system, coordination, speech, and gait. Cognitive testing, you may refer to the screening section in this module. Some may require more specific testing. For example, in frontotemporal dementia, they may require an in-depth speech assessment and a specific executive function testing to rule in or rule out. Testing is usually needed at presentation and is preferably repeated every 6 months, 9 months, and sometimes once a year. Screening for depression, I cannot emphasize enough how important this one is, because pseudodementia is not uncommon in this population. You can use the PHQ-9 or the Cornell scale for depression in dementia. You should also screen for other neuropsychiatric symptoms using either the Neuropsychiatric Inventory or the DSM-5 self-rated level 1 cross-cutting symptom measure, which the patient can fill out on their own. Next is lab work. This is the standard battery that we order for patients presenting with cognitive impairment. It includes a CBC, a metabolic panel, a hemoglobin A1C, screening for syphilis, TSH, vitamins D, B1, B6, B12, and folate, a urinalysis, and in some cases, a drug screen and HIV testing may be needed. Brain imaging. So the best initial is an MRI without contrast of the brain with volumetric measures if they are available at the screening center, or the MRI machine can do it. A CT head without contrast if the MRI is contraindicated or the MRI is not applicable. So some cases will require some special testing, like special neuropsychiatric testing may be required for special populations like illiterate patients. Um, Lab work for autoimmune markers may be indicated based on history and exam. Genetic testing may be indicated for some patients. Advanced neuroimaging like a PET scan, a SPECT scan, a functional MRI, or a DAT scan. A lumbar puncture, an EEG, and an EKG are sometimes indicated. So one last notice I have to say about this section is that good practice requires revising the diagnosis periodically as the clinical presentation evolves. It's not uncommon that you have a preliminary probable diagnosis, but as the picture evolves, you may need to revise your diagnosis and your treatment plan accordingly. Most of these diagnoses are only definitive by autopsy, so diagnoses are usually possible or probable, and follow-up is quite crucial. It's not just a park and go. You say this patient has a frontotemporal dementia, and that's about it. You should follow these patients because things may change and may evolve into different scenarios. So now we arrive to the last section of this module, in which I will try to answer a common clinical question that patients or their families may ask about what exactly can I do to prevent or slow down my cognitive decline as I age. So here's a list of the stuff that you can do that medical research have proven to prevent, delay, or slow down the progression of cognitive decline in older adults. These include maintaining physical exercise for at least 150 minutes per week, optimizing cognitive and social activity as much as tolerated, treatment of medical risk factors such as hypertension and hyperglycemia, smoking cessation, and minimizing alcohol use as much as possible. On the other hand, items on this list do not have enough evidence at this point that they prevent, slow, or delay the progression of cognitive decline. These include vitamins without any evidence of deficiency, estrogen replacement therapy, nonsteroidals, anti-inflammatory drugs, or cholinesterase inhibitors. And this is a list of some items that may help with cognitive decline in older adults, but they require more evidence to back them up. These include consuming Mediterranean diet, or the MIND diet, which is a mix between Mediterranean and DASH diet, vitamin E and omega-3 fatty acids, consuming berries such as strawberries and blueberries that are high in flavonoids, taking statins, and there are ongoing studies for the use of anti-amyloid therapies for asymptomatic subjects who have proof of amyloid deposition in their brain. In this last slide, I'd like to highlight the role of education in that space. So higher education increases the cognitive reserve of individuals, which may delay the onset of neurocognitive symptoms compared to the burden of the neuropathology in the brain. But once the dementia symptoms start, rapid cognitive decline is actually common. So imagine education as a form of a barrier that blocks the impact of brain pathology on the cognition and delays the onset. But once that barrier is broken, the pathology becomes very impactful on cognitive functions and the decline becomes much more rapid. So to summarize what we've covered so far in this module and share some key points and high-yield take-home messages, neurocognitive disorders in older adults has an extensive range of differential causes, and each underlying cause presents with a variety of non-cognitive symptoms, such as motor, autonomic, or neuropsychiatric manifestations. There is a significant degree of overlap between these different etiologies, and for several neurodegenerative etiologies, only autopsy can confirm the diagnosis, so clinically we can only make a probable or a possible diagnosis. Learning different syndrome presentations makes a lot of difference in their prognostication and management. For some cases, early detection and prevention is key to a favorable outcome. Careful and systematic diagnostic approach is crucial to narrow down the list of your differential diagnoses. So, Alzheimer's disease by far is the most common cause of cognitive impairment in older adults, but it remains a diagnosis of exclusion, which means that you need to rule out other alternate or comorbid causes of cognitive impairment. Depression is a common treatable comorbidity that may also masquerade as dementia, particularly in older adults. While there is no cure for most neurocognitive disorders, patients' caregivers can still benefit from preemptive care planning, symptomatic treatment to decrease the disease burden, and treatments that may slow down the disease progression. Care should always be continuously tailored around what matters most to the patients and their caregivers to attain the best possible quality of life. Now I thank you all for paying attention through this lengthy module, and I hope it helps you enough with helping older adults who suffer from cognitive impairment.